one of the most commonly tested cardiology drugs. You'll see them used frequently. Say you had a patient in the hospital admitted on a nitroglycerin drip for hypertensive emergency. His blood pressures on this are well controlled, most recently 130s over 90s. But despite this, the patient reports having a progressive headache. There have been no other changes in medications, and there are no abnormalities on physical exam. What is the most likely mechanism behind his headache? Well, what's nitro do? It's a venodilator, and dilation of the stuff in the brain, this may sound like an oversimplification, and it probably is, but it causes headache. And this might be a dumb way to remember this pathophysiology, but recall that we use vasoconstrictors like sumatriptan to treat migraines, whereas vasodilators like nitrates cause them. By the end of this video, I want you to list 3 commonly used nitrates and when you would use them, describe nitrate's mechanism of action, and list contraindications to nitrate use. Finally, you should be able to recognize common adverse effects. 3 drugs that belong to the nitrovasodilator group are nitroglycerin, isosorbide dinitrate, and mononitrate. These are called nitrates because all of them have a nitrogen bound to 3 oxygens. You're responsible for knowing all of the names, but none of the chemical structures. This is isosorbide mononitrate and dinitrate with 1 and 2 nitrate groups respectively. And this is nitroglycerin, named because it has 3 nitrates attached to a glycerol molecule, so nitroglycerol. Again, you do not need to know the structure, so don't memorize those. The only point here is that they have similar structure and thus function. When you give a patient one of these drugs, these nitrate groups are liberated as nitric oxide. The eventual increase in nitric oxide increases soluble guanylate cyclase in vascular smooth muscle cells to make more cyclic GMP. The end result of this is venodilation more so than arterial dilation. Therefore, what do you expect would happen to preload? Right, we have venodilation, and so more blood is being pooled in the veins because they're dilated, so the preload will go down. More blood in the veins means less is going to the heart. If you give your patient too much of these drugs, there can be a significant amount of vasodilation, which can lead to side effects like facial flushing and headache. The dizziness can be attributed to an excessive drop in blood pressure, decreasing perfusion to the brain. So that is the mechanism of action, but when would we actually use nitrates? Because they drop preload and thereby decrease myocardial oxygen demand, they are most commonly used in angina, acute coronary syndrome, and pulmonary edema. So why is it important to decrease preload by venodilating with nitrate in any of these cases? Well, remember this equation when you're thinking about preload. Venous return equals venous pressure minus right atrial pressure. Venodilation drops venous pressure, and therefore decreases venous return to the heart. By decreasing the volume of blood returning to the heart, we decrease the wall tension and thus the amount of ATP required by the myocardium, and this in turn helps decrease myocardial oxygen demand. Alright, let's push on to toxicities and adverse effects of nitrates. Alright, so what is Monday disease? People that work in nitroglycerin manufacturing factories can inhale nitrates. They have exposure and therefore develop tolerance during the work week, Monday through Friday. On the weekend, they have no exposure, Friday night through Monday morning, and lose their tolerance. And then upon re-exposure, when they return to work on Monday, they vasodilate drastically and have a large drop in blood pressure on Monday, leading to decreased perfusion. This can present as dizziness or as headache, again because we have venodilation in the brain, on Monday, hence Monday disease. So what physiologic response would you expect to see from the heart in response to a drop in blood pressure? Well, if the blood pressure drops, the heart rate should increase to compensate, turned reflex tachycardia. So what, therefore, is one of the common side effects of nitrates? Yeah, reflex tachycardia. You can treat this sympathetic outflow surge with beta blockers. So based on the fact that nitrates drop preload, In what type of myocardial infarction are nitrates contraindicated? Well, the right ventricle is preload dependent, meaning that it requires preload in order to fill so that it can eject an appropriate amount of blood. If you have a right ventricular myocardial infarction or an inferior myocardial infarction, the muscle cannot contract, and so the preload is the only thing that's optimizing the Starling curve and the main thing pushing blood forward. And therefore, in right ventricular MI, you drop preload at your peril. So in what conditions is increased preload especially important? And I'll give you a hint. One of them, at least the one I'm thinking about, is a cause of exertional syncope in young patients. Yeah, that would be HOCM, or hypertrophic obstructive cardiomyopathy. Alright, ignore the patent ductus arteriosus here. This is just an especially good image to illustrate what I'm talking about. So in HOCM, the more plump the ventricle is, the less of an outflow tract obstruction there is. As you can imagine here, the narrower the outflow tract is, the more the blood flow would be obstructed. You therefore want to keep preload high to keep this open. Another important situation that you'll definitely be tested on is a contraindication we've all heard about. So I don't know if any of you have seen those Viagra or Cialis commercials, but in the closing segments, you can hear the narrator always say, "Do not take if you're currently taking nitrates for chest pain." So why would it be a bad idea to take a phosphodiesterase inhibitor for erectile dysfunction if you're also on nitrates for chest pain? Well, the nitrovasodilators increase cyclic GMP, while the phosphodiesterase inhibitors ending in denafil, like sildenafil and tadalafil, block cyclic GMP breakdown. The result is an accumulation of tons of cyclic GMP, and this can lead to an unsafe and dramatic drop in blood pressure due to a vasodilatory response. This is a general pharmacologic principle that you should remember. Don't double up on drugs with a similar mechanism of action. Similarly, you wouldn't want to use a calcium channel blocker and a beta blocker in the same patient because they are both AV nodal blocking agents. Alright, what are 3 contraindications to nitrates? So I want you to notice that all 3 of these are due to decreased preload. You don't want to drop preload in a right ventricular MI because the RV is preload dependent. You don't want to drop it in hypertrophic cardiomyopathy because the more plump the ventricle is, the less of an outflow tract obstruction there will be. And you don't want preload to drop with PDE5 inhibitors because PDE5 inhibitors are already doing that. Alrighty, let's wrap up. So nitroglycerin, isosorbide dinitrate, and mononitrate are the 3 commonly used nitrates. They work by causing a nitric oxide and cyclic GMP-related venodilation. Due to their venodilation, you want to have caution in conditions where low preload would be dangerous, such as HOCM, right ventricular MI, and diestrase inhibitor use. And common adverse effects include Monday disease, hypotension, reflex tachycardia, and headaches. So thank you guys so much for tuning in. If you liked the video, go ahead and give me a thumbs up down below, and as always, comments are more than welcome. Study hard and stay healthy, my friends.
Let's say we have a 57-year-old man with a medical history significant for angina and hypertension presents because of worsening chest pain. He treats each episode with sublingual nitroglycerin, but has noticed that over the past year, the frequency of his episodes has increased from once a week to daily. A note in the chart indicates that the patient is allergic to metoprolol, so a calcium channel blocker is added to the patient's regimen. Which calcium channel blocker is most indicated? In this lecture, we will explain the mechanism of action of calcium channel blockers, identify the clinical uses for calcium channel blockers, and identify some of the adverse reactions that we can expect with calcium channel blocker use. The main difference between the dihydropyridines and non-dihydropyridines, besides the non in the beginning of the name, is that the dihydropyridines block the calcium channels on smooth muscles, while the non-dihydropyridines tend to favor calcium channels on the heart. Let's talk mechanism of action first. Recall that L-type calcium channels are located in the myocardium and are also responsible for pacemaker cell depolarization. Our non-dihydropyridines, verapamil and diltiazem, bind voltage-gated L-type calcium channels of the individual myocytes and also the pacemaker cells. This image from the cardiophysiology section is our cardiomyocyte, and on its sarcolemma, we can see the L-type calcium channels that we are going to block. This will drop contractility because there will be a decrease in the amount of intramyocyte calcium. Remember, the amount of calcium directly relates to contractile ability. Verapamil is more selective for the L-type calcium channels in the myocardium than diltiazem. These guys are also useful for binding the calcium channels that pacemaker cells use for their phase 0 depolarization. If we bind the calcium channels responsible for the upstroke in phase 0, we are going to drop the rate at which we create and conduct depolarizations. This is why verapamil and diltiazem are useful in situations in which we want to drop AV nodal conduction speed, like AFib or aflutter. Why do we want to decrease AV nodal conduction speed in the situation of AFib or aflutter? That's because we do not want every single depolarization from the atria transmitted into the ventricles. Calcium channel blockers help increase the refractoriness of the AV node. Now, we shift gears into the dihydropyridines. They all end in dipene. These guys preferentially block vascular smooth muscle cells with less effect on the myocardial calcium channels, except amlodipine and nifedipine, which have equal affinity for both types of calcium channels. The dihydropyridines are more selective for vascular smooth muscle cells, so their clinical utility is for vascular tone issues, such as in hypertension and in spastic or Prinzmetal, angina, or Raynaud phenomenon. Let's apply this to see how we use this principle to treat a patient with subarachnoid hemorrhage. This patient wasn't very lucky and suffered a ruptured cerebral aneurysm. Remember, there are 3 layers covering the brain from outside to in. It's the dura, the arachnoid, and the pia mater. The subarachnoid hemorrhage means that blood is hemorrhaging into the space below the arachnoid. Blood will irritate the cerebral vessels and can increase the risk of vasospasm. What type of calcium channel blocker would you use? Would you use one like verapamil that has a high cardioselectivity? Or one like nimodipine that mainly antagonizes vascular smooth muscle channels? Nimodipine is the way to go because we need a dihydropyridine that will inhibit the calcium channels on the vascular smooth muscles of the cerebral vessels. In addition, you can give the dihydropyridines or a non-dihydropyridine for someone in the situation of hypertension because they will both drop the blood pressure, but in different ways. Remember the equation: blood pressure equals cardiac output times total peripheral resistance. Your dihydropyridines will tend to drop blood pressure by arterial vasodilation, leading to a drop in total peripheral resistance. The non-dihydropyridines will tend to cause a decrease in the cardiac output by decreasing the heart rate and contractility. Medications like nicardipine and clevidipine are useful in hypertensive urgency because they have a fast onset and a short duration. You want to quickly drop these patients' blood pressures, but if you overshoot, you also want the drug to be metabolized quickly so that you can readjust your dosing regimen. The toxicities associated with these drugs are directly related to their mechanisms. The cardiac depression and AV block caused by our non-dihydropyridines verapamil and diltiazem, should be rather obvious to us because we are directly blocking the calcium channels that are responsible for the intrinsic depolarization rate of the cells that control heart rate. The peripheral edema, flushing, and dizziness are all related to vasodilation. If you dilate your vessels, you can increase the fluid shifting across your vessel wall into the interstitium, leading to edema. Flushing is because you increase the diameter of the skin vessels, increasing the flow of red blood in the skin. This side effect makes the person look very red like a cherry. The dizziness is a combination of a drop in cardiac output and total peripheral resistance, causing hypoperfusion to the brain. The constipation is associated with the calcium channel antagonism of the interstitial cells of Cajal. Do you remember what these cells are responsible for? The interstitial cells of Cajal set the baseline depolarizations of the intestinal smooth muscle and control gut peristalsis. A unique adverse effect that isn't completely understood is gingival hyperplasia. The last adverse reaction is high yield because it lets the test question writers bring in some endocrinology. Hyperprolactinemia classically occurs due to verapamil. How in the world does verapamil lead to an increase in prolactin levels? Well, the arcuate nucleus in the hypothalamus has neuroendocrine neurons that produce dopamine and then packages it into vesicles. The release of dopamine from the vesicles is dependent on calcium influx. Verapamil is the bad guy here and inhibits this calcium influx. What happens when we do not have enough dopamine to bind and inhibit the lactotrophs of the anterior pituitary? Well, they are not inhibited from producing prolactin, leading to hyperprolactinemia. Flash quiz time. Among the calcium channel blockers, which acts most like nitrate in treating angina, and which acts most like a beta blocker? The answers would be nifedipine and verapamil, respectively. Remember that the dipines will drop blood pressure by arteriolar dilation, while the non-dihydropyridines will tend to cause a decrease in the cardiac output by decreasing heart rate and contractility. In this video, we learned that calcium channel blockers come in two different flavors, the dihydropyridine and non-dihydropyridines. The dipines tend to work on vascular smooth muscle, while non-dipines work more on cardiac myocytes. Some of the associated adverse drug reactions include edema, flushing, cardiac depression, and the rare gingival hyperplasia. Thanks for watching, and be sure to click thumbs up if you enjoyed this video.
Hydralazine is a drug that you guys will see daily on wards. Its use is frequent, and there are uses for which there's actually a mortality benefit. So in short, you should know it, making it a fantastic fodder for boards questions. By the end of this video, I want you guys to be able to describe hydralazine's mechanism of action, as well as some of its clinical uses, and cite potential adverse effects. Hydralazine is a potent vasodilator that acts primarily in the arteries and arterioles with no effects on systemic veins. So let me repeat that for you. It only inhibits vasoconstriction of arteries and arterioles with absolutely zero effect on systemic veins. So how does it work? Here's our diagram showing endothelial and smooth muscle cells of a vessel. Hydralazine increases cyclic GMP. Cyclic GMP will bind and liberate protein kinase G inside of the smooth muscle cell. And this phosphorylates IP3, which decreases calcium influx from the sarcoplasmic reticulum of muscle cells. As always, less calcium means less contraction, and less vascular smooth muscle contraction means less constriction, and therefore vasodilation. So what does arteriolar vasodilation do to our afterload? While if afterload is the load that the heart has to pump against, then vasodilation will decrease it. For this reason, hydralazine is particularly useful in treating acute hypertension. It's also one of the few antihypertensive drugs that can be used in hypertension in pregnancy. You can give this to a patient with heart failure, but you have to make sure that you also include an organic nitrate to venodilate. In this setting, you drop the afterload with hydralazine and drop the preload with the nitrate. If the patient's not in heart failure, then you usually get a beta blocker at the same time as hydralazine. So why might this be? Well, it inhibits the baroreceptor reflex. So we just caused a huge drop in the patient's afterload. And as a result of this, the stretch receptors in the aortic arch and the carotid sinus are going to sense this change and increase sympathetic output in order to prevent decreased perfusion to the brain. The heart responds to this by increasing cardiac output, including an increase in heart rate. All right, on to side effects and contraindications. We'll run through these quickly and then come back to them. So these are reflex tachycardia, fluid retention, angina, headache, and drug-induced lupus. Hydralazine is also contraindicated in angina or coronary artery disease. So reflex tachycardia we just covered. Afterload and blood pressure go down, so it's common to have a tachycardic response. Fluid retention and headache I remember in a related way. Hydralazine is a vasodilator, and so it causes things to dilate. The legs get bigger, as do the cerebral blood vessels. This is far from the most scientifically complete way to remember things on test day, but you're not going to be tested on these mechanisms. If it helps you remember it better, it's also worth recalling that this information is actually reconcilable with headache treatments. So remember what the mechanism of action of triptans is? Well, they're given for migraines and they're vasoconstrictors. So as we've learned here, vasodilation, in this case of arterioles, with hydralazine can cause headache, and vasoconstrictors relieve that. The anginal component here is a bit complicated. When people have coronary artery disease, their coronaries are often calcified and not very compliant. Therefore, when you give an arterial vasodilator, the only coronary arteries that can vasodilate are the ones that are less diseased. So when you give vasodilators to a patient with CAD, it can, therefore, shunt blood towards the healthier vessels and away from the diseased ones that can't dilate. This is why it can cause angina, as well as why it's contraindicated in that case. Finally, hydralazine is one of the drugs that can cause drug-induced lupus. So what is the very high-yield antibody that you can look for in the serum to determine if lupus is a consequence of a drug? Right, that would be antihistone antibodies. All right, guys, time for a flash quiz. So what two drugs in the cardiology section cause drug-induced lupus? Well, one we just covered, that's hydralazine, and the other is procainamide. Quick summary. Hydralazine's mechanism of action is arterial vasodilation and an increase in cyclic GMP. Because it reduces afterload, it's used in hypertension as well as heart failure. Its adverse effects, as with all drugs, is related to its mechanism of action. So hydralazine causes reflex tachycardia, fluid retention, headache, and angina, and is contraindicated in angina as well as coronary artery disease. So thank you guys so much for tuning in. If you liked the video, go ahead and give me a thumbs up down below, and as always, comments are more than welcome. Study hard and stay healthy, my friends.
Alright everyone, we've reached hypertensive emergencies, which is when someone is presenting with an outrageous blood pressure and clinical signs of elevated pressures. So first, let's discuss sodium nitroprusside. Organic chemistry was certainly not my favorite class, but showing the structure of this drug explains its mechanism and side effects. This drug can basically be described as an iron making most of its bonds with cyano groups and one bond with a nitroso group. Our nitroso group is the nitrogen triple bound to oxygen. This nitroso group looks like a nitric oxide already, doesn't it? It's ready to go. So this is why it acts so fast. This nitroso group pops off and we get immediate increase in nitric oxide. This increases cyclic GMP and leads to smooth muscle relaxation, which helps drop the patient's blood pressure immediately. So what is the big concern with this drug? That's right, cyanide toxicity. And why do we need to be concerned about cyanide toxicity? Well, look at all these cyanide ions hanging off the iron. How is cyanide toxic? Alright, so test writers love biochemistry, and so anytime they can quiz you on it, they will. So here's a little practice. So here we have complex 4, also sometimes called cytochrome C oxidase, because it takes electrons from, aka oxidizes, this electron carrier called cytochrome C. So basically, complex 4 is on the lookout for electrons or electron-rich molecules. So guess who else is very electronegative? Cyanide. This means that it will competitively bind to complex 4, and this will inhibit the passing of electrons and therefore limit aerobic respiration. So the patient you gave nitroprusside to finally has lowered their blood pressure, but then, all of a sudden, they start exhibiting decreased consciousness or altered mental status, weakness, headache, and confusion. But wait a minute, we just made them better. What happened? Cyanide toxicity. Our patient is showing signs of cellular hypoxia because cyanide inhibited the electron transport chain, which led to conversion from aerobic respiration to anaerobic respiration, with eventual tissue hypoxia. Okay, so will someone just present with these signs and symptoms? Yes, of course. But the test vignette must include some type of risk or clue that the patient was exposed to cyanide. The most common way people are exposed are by house fires, also followed by industrial production of heavy metals or plastics, or excessive intake of nitroprusside. Another important molecule that can also inhibit complex 4 is, yes, carbon monoxide. Never forget these two. So how do we treat cyanide toxicity? That's right, thiosulfate, because it will directly bind the cyanide and remove it off the complex 4. This is the chemical structure of phenoldiazepam, and this is the chemical structure of dopamine. Ah, Pete, why are you torturing us with these structures? Well, look at the similarity between these two compounds. Phenoldiazepam was named so because it is literally almost the exact same as dopamine with a phenol group attached. Phenoldiazepam. Get it? It looks just like dopamine and acts as an agonist at dopamine A1. Okay, big deal, so who cares? Well, a patient in hypertensive emergency cares a lot. Phenoldiazepam is specific for D1 receptors in the peripheral, coronary, renal, and splanchnic vascular beds. This means that we get a huge drop in blood pressure because all these vascular beds will vasodilate. This is why it is one of the drugs used for a hypertensive emergency. We want systemic vasodilation to decrease the patient's pressure in a large way. It also increases natriuresis by inhibiting sodium reuptake within the renal tubules. So clearly, this drug has the potential to cause hypotension and a reflex tachycardia.